Okay, this young man was stabbed, I believe, by the same friends that stabbed him the time before. Came into, this was at San Francisco General Hospital, so he was stabbed in the chest, and this was the first set of films. He obviously wasn't in too much distress because we got a, sorry, I should be in front of the microphone, because we got a PA and lateral on him. So, any ideas? Hematoma. Well, obviously the first thing one reasonably thinks about. So the only problem was he actually was stabbed on the left side of his chest, so we knew that. He wasn't terribly sick, so he went ahead and got a CT scan after he got a chest tube on that side. And the CT scan showed this abnormality. So obviously, could be a hematoma. This is without contrast, I think, yeah. Right, well, you've got basically an anterior/middle mediastinal mass, probably more in the middle, and the differential diagnosis, of course, includes teratoma and thymoma. This was a young person. There are some calcifications in it, but because he was stabbed, he went to relatively prompt angiography, and this was his angiogram. So we have a large mass here adjacent to the aorta and the subclavian artery, brachiocephalic artery, which is vascular but is not in itself a mass filled with blood. So it is not likely to be a pseudoaneurysm. We saw with the calcifications that it's not likely to be that either. And then late phase, it fills in. So the differential diagnosis that we were thinking at the time, hematoma, obviously, not very likely since he wasn't stabbed anywhere near that. Lymphoma, reactive adenopathy, duplication cyst, bronchogenic cyst, neuroenteric cyst. It's a little far anterior for it. Pseudoaneurysm, of course, you have to consider, but the diagnosis turned out to be Castleman's disease. Often a cause of lymphadenopathy in the neck. This was it can occur in the mediastinum, and usually these masses are asymptomatic and fairly benign. This one was the hyaline vascular type. You can have a more aggressive collection or lymph node mass that has a tendency to degenerate into more neoplastic conditions. So Castleman's disease, there are a few other variations on it. Something to keep in mind, and also something to keep in mind is that when you are dealing with trauma, you may uncover non-traumatic conditions at the same time. Okay, next patient had, actually these are two patients, both of which presented with cough and fever for the purposes of this talk. So here is patient number 1, and here is patient number 2. Acute or remote? Well, a couple problems for this one. First of all, it's the right side, which is not where you usually see traumatic rupture of the diaphragm, because the liver tends to protect the diaphragm. I suppose it's possible to be a lot of diaphragmatic contents. Certainly you're noticing the air fluid level here. But in this patient, we have something else. We have this abnormality on this side. So we have a cavitary lesion here, and we have a large mass in the chest here with a fluid level. And, I'm sorry?
No gastric bubble.
No gastric bubble. Yes, certainly not in the chest. This one, who has the same condition, has a large mass here, which is basically pleural-based. It's somewhat dependent in the chest and aligned along the posterior pleura. This does not have an air fluid level in it. And so diaphragmatic, you can get late diaphragmatic ruptures and herniation of bowel contents, and that's worth thinking about. There was no history of a remote motor vehicle accident. Certainly in an acute situation, you'd expect to see a lot more damage if you were going to rupture a diaphragm like that and not get a PA and lateral film. So here's the CT corresponding to the first patient. And we have a fluid collection, which is pleural-based with thickened, enhancing pleura and a combination of thickened pleura and possibly collapsed lung ventrally. And then in the other patient, we have a similar collection with enhancement of the pleura a bit of air in here and then some collapsed and consolidated lung. So the diagnosis, anyone? Any ideas? Okay, well, just to hurry this one along, these are both cases of very large thoracic empyemas, okay, which often occur in association with pneumonia, but may occur outside of that situation. The second patient that had a small cavitary peripheral lesion, which was a septic pulmonary embolus. Usually they're elliptical or lenticular, and they may be non-dependent. Complications include bronchopleural fistula. When you have a rupture of the visceral pleura into the empyema space, you can get air collecting in there. You may also see air in this cavity due to thoracentesis or gas-forming organisms. When the chest wall is involved, you need to consider certain agents such as tuberculosis, actinomycosis, or nocardia. Okay. This patient complained of a puffy lump on his chest, which got worse and better depending on the moment. Lung herniation. This is exactly lung herniation. The real history was that in addition to having a puffy lump on his chest, he had had a peripheral carcinoma resected a year before. And these are usually either post-traumatic or post-operative. They may be congenital. When they are congenital, they tend to occur at the lung apex. And these are puffy bulges that can enlarge with Valsalva maneuver. There was a recent image in the images section at the New England Journal of Medicine of someone who had developed a lung herniation from aggressive CPR. That's probably why everybody got this one so quickly. All right, so this patient was in a motor vehicle accident. Okay, that's a good observation. A little air in the neck. Tension pneumothorax. Okay, well, there is definitely a pneumothorax. Is it under tension? Possibly. This has shifted a little bit this way, but well, the lung looks a little funny for a pneumothorax. It's not collapsed directly towards the hilum, and so what they did was put in a chest tube, which is a fairly reasonable thing, and then they put in the chest tube, but they felt it was adequately positioned. I think there's also a little fracture here of the clavicle on the right. And what's the problem? Right, of course, the chest tube didn't work, so there is a communication between the bronchus and the lung. I don't know if you saw any cases like that earlier today. Tracheobronchial rupture. Most of them are going to occur near the carina and usually will involve the right main stem bronchus, as in this case. And the key is you're going to put in a chest tube even before you know there's a pneumothorax often, if the patient has significant chest trauma. And when you have a chest tube that should be working and doesn't expand the lung, then you need to consider this possibility. The fallen lung sign is a little more obvious on CT scan when the lung is actually dependent in the posterior aspect of the chest, but this one I think is sort of a quasi-fallen lung sign on plain film. Okay, another patient with a motor vehicle accident. This is sort of our typical ER chest film. At Bellevue anyway. Patient is on a stretcher, on a gurney, or a backboard. The film quality is, actually, this is pretty good. Usually it's much more atrocious. The mediastinum is fairly sharply defined, but if you sort of look through this, you see a fair amount of density over this left side here. And so this patient, like almost all of our patients these days, went on to get a CT scan. And Here we have a fairly peripheral, patchy areas of consolidation, mostly at in the back of the chest. The right lung is pretty clear, and these would be expected to improve relatively rapidly.
Pulmonary contusion.
Pulmonary contusion, exactly. And pulmonary contusion is defined as interstitial and alveolar lung injury without evidence of frank laceration. It's the most common injury resulting from blunt trauma, and generally this will resolve on the order of days to weeks. Pathologically, it's blood and fluid filling alveoli. Non-specific on chest radiographs. On CT scans, these tend to be peripheral and they're non-anatomic in distribution. And usually will occur, as I mentioned, promptly and clear fairly rapidly. Okay, this patient was a 28-year-old man, perfectly healthy, presented with a first seizure. And actually, the head CT was the first thing that was obtained, but we'll start with the chest x-ray. Poland syndrome. Okay, yeah, I see. I'm sorry. Yes, the left lung looks a little more loosened than the right, but that turned out not to be real. Just ignore that. But Poland syndrome, of course, we actually saw a case of that the other day. It wasn't truly Poland syndrome, which is where you have hypoplasia of the muscles of one side of your chest, but in this case, it was a prisoner who had been doing a large amount of exercise, weightlifting, and at some point in the past had ruptured one of his pectoralis muscles and then had atrophy as a result of it. True story. He was in CPAP. Okay, anything else on this film? It's a tiny bit of an eye test.
Well, the trachea and esophagus lines look fun.
I think they're okay. I'll give them to you.
Pulmonary AVM.
Pulmonary AVM, okay? So if you look, these vessels are going way too far out here and way too far out here. They're just too big. Admittedly, it's not as good as looking at it on the monitor, or in this case, plain film. It's fairly old. But vessels should really start to attenuate. And when you're seeing things that are this large, especially if you see pairs out at the periphery, you have to consider that. So any idea what his head CT should look like? Yeah, AVM. No, he didn't have an AVM in his head. Kind of. He had an abscess. So in the actual chronology of this was we saw the head CT first. Obviously, that's usually what they're going to get. And we saw this. We asked, well, is the patient immunocompromised? No, totally, perfectly, healthy guy. No other problems, no risk factors, no nothing. We said, well, looks like a brain abscess. Get a chest X-ray, look in his mouth. It's one of those rare moments when you get to be smarter than your clinical colleagues. And they did get the chest X-ray. We got a CT scan, which shows these paired vascular structures, or tubular structures, I should say. Sorry, oh, and I think there may have been one here too as well, yes. So he went to angiography. You can see a arteriovenous malformation here. This is one of them, which was successfully coiled. And indeed, this was a case of pulmonary AVM presenting in a previously healthy asymptomatic person. Most of these are associated with hereditary hemorrhagic telangiectasia or Osler-Weber-Rondeau. Usually, these are asymptomatic because they develop slowly and people accommodate to chronic pulmonary hypoxia if they're large. But there are other problems, and in this case, the problem is really paradoxical embolus and brain abscess. They will seed their venous. We all seed our venous systems, of course, with bacteria, but the lungs act as a filter, and in this case, don't do a very good job of it. So patients can present with brain abscesses. They can develop arteriovenous malformations in the brain, which are not really true AVMs. And then, of course, these AVMs in the lung can rupture and cause hemorrhage as well. The other problem is patients can become polycythemic as a result of the chronic hypoxemia and develop infarcts as a result of that. So just to review, and mostly for the purposes of the CD-ROM that you're getting at the end of this course, Oster-Weber-Rondeau hereditary hemorrhagic telangiectasia. Clinical findings include nasal, dermal, and GI telangiectasias, but the main problems that people have are related to the pulmonary arteriovenous malformations with stroke and brain abscess being rather poor prognostic signs. Okay, this patient was far too sick for clinical evaluation. Therefore, we were given the opportunity to make the diagnosis. I hope everybody here is a radiologist.
Too sick for a physical exam?
Way too sick for physical examination.
The ER doctor couldn't open his eyes.
They had to transfer them immediately. Okay. No, this patient was in extremis, was extremely ill when they came in. They did in fact get looked at by the emergency room doctors, and this was the ER film. They were a bit on the hypotensive side and just did not look good. Okay, so well, there are some findings here we can talk about. This film is a bit light. I'll show you a slightly more penetrated version of it. But obviously, the mediastinum here is abnormal. It's sort of ill-formed, it's wide, and we have a pacification of the left hemithorax. So probably, if not certainly, a pleural effusion, an abnormal-looking mediastinum, and a patient who's quite ill. One of the nice things about having a PAC system is you can get old films rather quickly, and this was the patient's prior study. Septic aneurysm. Dissecting aneurysm, yeah.
Dissection.
A dissection, which is what this turned out to be, was not that much of a challenge. But it illustrates some of the useful findings that we can look at. First of all, this patient is elderly and has a calcified aorta. Here you'll notice the trachea is midline, the left main stem bronchus is more or less where it should be. The heart size is maybe a little bit big, but not too exceptional. This is the CT scan that went along with this, and indeed we've got a true lumen, probably a false lumen filled with clot, and certainly a rupture with a hematocrit level. Here, higher density blood and somewhat lower density blood and pleural fluid and serum above it. So I will, before I go into my word slides, just show you a companion case. This patient was less symptomatic and simply presented with back pain. This is a more typical appearance for a non-rupturing but dissected aorta, type A, which, as you know, includes the ascending aorta, and type B is limited to the descending aorta. It can be challenging to figure out which lumen is the true lumen and the false lumen. Probably the best way is to find an area that isn't dissected and follow that up. In this case, this really went all the way through, but I believe that the left side here was the true lumen, which did not obstruct the celiac axis. But this was a type A dissection. So, a couple small facts about aortic dissection. A typical presentation is going to be acute back and chest pain, may be associated with hypotension, as in our first patient, can present with sudden death. Type A's involve the ascending and the descending aorta. Type B's are limited to the descending aorta. The mortality in the first 24 hours can approach 25% if untreated. And 15% of these patients may not have symptoms to speak of, may dissect silently. Radiographic findings. The first case really illustrates all of the key findings in a rupturing dissection. Widened mediastinum, displaced intimal calcification, pleural effusion, tracheal shift, and depression of the left mainstem bronchus. And here is a more penetrated view that shows all of those things. Here's the margin of her aorta, which is separated now from the edge of her mediastinum. The trachea is pushed to the right, the mainstem bronchus on the left is depressed, and there is a large associated pleural fluid collection. some predisposing conditions, atherosclerosis obviously, trauma, aortitis from whatever cause, hypertension, cystic medial necrosis, and Marfan-Ehlers-Danlos syndromes. Okay, well, often in the emergency room, we are expected to read every pre-op case, every pre-op clearance film in the hospital, so this is an example of one. It's only history pre-op. And of course, usually on the pre-op films, what we're most worried about missing is the lung cancer that's going to, come back to haunt both the patient and us in some time. Okay, anaplastic thyroid cancer. That's a good answer, but it's not the right answer.
Well, the rib's gone, so, I mean, the clavicle's gone.
Okay, so you have to worry about neoplasm that's dissolving the patient. Of course, we get no history to speak of 50% of the time. In fact, pre-op is a pretty good history. But that's true. The right clavicle is, for the most part, absent. Maybe it's here and it's abnormal, and there's a soft tissue density here, which is not present here. And here we have a pretty clearly defined nodule. So this is when we normally get on the telephone and try and find out, what exactly is going on with your patient. Of course, we get these films at 7 at night, and there is nobody to call. But fortunately, we usually can figure it out by going through old films. And this was the lateral that went along with that. Does this tell you anything about what might narrow this mysterious collection of findings down to?
Didn't the patient already had some lung resection?
I don't think so. But they were well known to the medical center. They had had many other issues. Yeah. I'm not sure if that's. Yes, very good. And occasionally, once again, when we get films for one reason, it turns out to be for something completely different. We didn't know this when the film came through as a pre-op film, but we figured it out very quickly. We confirmed our suspicions looking at the old films, the numerous old films of the patient's spine and other things. Neurofibromatosis, or von Recklinghausen's neurofibromatosis, NF1, is located, it's an abnormality of a very large gene located on chromosome 17. It's autosomal dominant. These patients have a inability to prevent numerous kinds of tumors from forming. They tend to have multiple cutaneous neurofibromas. They can get large plexiform neuromas, which traverse fascial planes, which go anywhere nerves can go, and can do a lot of destruction in terms of remodeling bone. And hence, in this patient's case, there was a large plexiform neuroma that had distorted the clavicle. You can have directly dysplastic bones, particularly the sphenoid wing in the skull. Patients often have scoliosis, and then there are some other things that they're at risk for, including optic gliomas. In terms of making the diagnosis, several things, there's a number of criteria, but they include Lisch nodules, which are small hamartomas on the iris that you can see with a slit lamp exam, cafe au lait spots, and axillary freckling, particularly in patients who are young and don't have a lot of cutaneous neuromas. Those are helpful diagnostic features, and if it is ever important for any of us to make the diagnosis in someone, they're available in books to look up the precise criteria. Okay, you have probably already been through at least 1 or 2 lectures on this subject. So, but it's one of the most common things that we see at NYU in the emergency room. Rule out pulmonary embolism, and if you don't see it commonly, you will over the next year or two. It is becoming the chest X-ray for chest pain in the emergency room now. So here's one example. These are all a collection of several different patients just for your viewing pleasure. This patient presented with a pretty severe chest pain, and as you can see here, we've got clot in both main pulmonary, both right and left main pulmonary arteries. So this is a big saddle embolus. It is not challenging to make this diagnosis on spiral CT. These are not the the hard ones, and in fact, the sensitivity and specificity for CT in the setting of a large central pulmonary embolus is almost 100%, which sure beats doing pulmonary angiograms. This patient also has a fairly large left descending pulmonary artery embolus. These are acute. You can distinguish acute from chronic, as you've probably already heard today. Acute emboli tend to be central, or portions of them tend to be central within the vessels. Chronic ones tend to marginate. You can have webs with chronic pulmonary emboli. But again, this is a large one, and if there's a clot this large, we should be able to detect it without much difficulty on helical CT scan. However, they get smaller. Segmental emboli can be a little bit more challenging to pick up. And ancillary findings are peripheral areas of consolidation or pulmonary infarct, mosaic perfusion, which is differential perfusion and differential density of the lung parenchyma, can also be seen in pulmonary emboli. And this is that same patient that has a small subsegmental embolus visible heading out to that segment of lung. To summarize some of the data, for central emboli, we should have about 100% sensitivity. Segmental, 50 to 100%, and subsegmental, maybe about a 50% sensitivity. Obviously, this depends on the quality of your scanner, the quality of your contrast opacification, but there are associated findings that can be helpful. Atelectasis, pretty nonspecific. Mosaic perfusion, seen in several other conditions I'll get to in a second. And then peripheral areas of consolidation or atelectasis and sometimes pleural effusions. Most of those findings really don't help you much. But you should, for the pulmonary emboli that are large enough to really matter, have a very good sensitivity with helical CT scan. There is some argument of whether or not, of how sensitive we should be in reading these tiny little peripheral emboli, because the consequences of anticoagulation are not entirely benign in and of themselves. But I don't think that's a question that is yet entirely resolved. Mosaic perfusion, which I showed on that last slide, can be seen in several conditions. Cystic fibrosis, which should be easy to distinguish, bronchiectasis as well, but also bronchiolitis obliterans and small airway infections can give that appearance, as well as chronic pulmonary emboli. Okay, this patient came in with several weeks of left arm discomfort and ptosis on the left. So the first thing they did, of course, was a head CT, which was completely normal. Fortunately, everybody who comes into our emergency room for any reason is going to get a chest X-ray, and well, unfortunately, as things turned out, this was this patient's chest X-ray. So, pardon? No, they did not do a PE study on that.
That's next week.
I'm sure that eventually she got one, yeah. Okay, so this is actually a very unfortunate person who presented with neurological symptoms, as well as really just neurological symptoms referable to the brachial plexus and the sympathetic chain, giving her a Horner syndrome, as well as weakness, probably from invasion of the brachial plexus. And her ribs and a fair chunk of her vertebrae are actually also missing here. If you look at the cervical vertebrae, you can see the lateral masses here, and here they start to disappear. So, and then coming down to the lung, there's a large mass. And yes, the whole first and second rib are pretty much dissolved. So this is obviously a Pancoast tumor. Primary lung carcinoma rising in the apex, which then goes on to, because they tend to be fairly silent from a pulmonary standpoint, they can go on to cause neurological problems as they erode up into the brachial plexus. The lateral view doesn't really add much here. But we have, these days the good fortune to be able to do fairly decent reconstructions. These aren't the best in multiple planes, so we can really get a good idea from a CT scan of her cervical spine exactly the relationships between this mass and the vertebrae. And you can see here that it is eroded into the spinal canal laterally at about the T3, T4 level. MRI provides even more gruesome depiction of the extent of this tumor here extending into and around the spinal canal. So again, this is a Pancoast tumor, primary lung carcinomas in the apex, invasion of the lower brachial plexus, subclavian vessels, thoracic ribs, and the vertebrae. Typically, they'll present initially with arm pain and can go on to weakness and numbness, and a Horner syndrome is present at diagnosis in about 20%. So Pancoast tumor, sometimes something that looks neurological is arising in the lung. Okay, this is a real trauma patient, blunt injury to the chest. Certainly blunt enough to merit a couple of chest tubes before we even got the film. So any thoughts? Heart's maybe a tiny bit on the big side. I think it's probably all right.
Paraspinal hematoma?
Okay. Well, it's a something anyway. It's gigantic. So obviously, since this is a trauma case, I have to be showing you a huge fungating lung carcinoma, right? No. No, this is just trauma. This is a combination of lung contusion, which we saw before. But notice within it there are these air collections. And sort of the next step in traumatic lung injury after contusion is, and here it is on CT scan, there's the chest tube, which may have participated a little bit in the action here. There's another chest tube on the other side. So this is a little more energy than a contusion is going to get you a pulmonary laceration. And it's a very typical appearance for it. Indeed, it is the result of trauma and not something incidental in this patient. The lung can tear in numerous ways, from compression, from shearing forces, and the initial tear tends to form an oval cavity, which may or may not be filled with blood or air. They're usually about 2 to 5 centimeters in diameter, and they occur fairly promptly. These are often obviously going to be associated with lung contusions, same mechanism, and may be associated with hemothorax. They're divided into 4 types. I'm not entirely sure what the value of that classification scheme is, since I don't think you do anything different about them. But there are 4 types. One related to compression expansion, another related to shearing across the vertebral column, a third type, which is really a puncture injury from rib fragments or foreign bodies that come into the chest, and type 4, I don't know how somebody came up with this one, that tear at sites of previous pleural scarring. Now, this is one of my favorite patients. This is true. He really did come in for acute chest and back pain following a meal of bad lobster bisque, only we weren't told about the lobster bisque right away. All we were told was chest pain, rule out PE. Sign him up for a pulmonary arteriogram. And I shouldn't admit this, but I came in the morning. This was the first case. I walked in, and it had been preliminarily looked at, and the person who was on said, "Oh, it looks okay. Yeah, we're going to get a CT anyway. I'm not sure." However it was, this had been looked at, and the impression was that this was an okay, crappy, portable film. And the patient was on their way to get a CT scan. So I come in fresh, not having been up for 24 hours, and I look at this film. Here's the film. So it's our usual sort of crap portable film, but I was a little more alert. And I said, "Oh, this is funny."
Boerhaave.
Yeah. So the first thing we saw was here. Little air in the neck, little air in the mediastinum, left pleural effusion. Sorry, it's not the most beautiful film. And we had no history of the lobster beast. I actually went out to the emergency room. I said, "Well, what's going on here? Like, you guys notice that his neck is crispy?" So he was a delightful elderly guy, not in a lot of pain, in a little bit of pain. Yeah, he said, oh, yeah, it sort of sounds like Rice Krispies here. So he had a little air in his neck. And I said, well, what's going on? He said, well, you know, last night I had this terrible lobster bisque and I threw up a bunch of times. And then all of a sudden I was having this back pain. So we pretty much clinched the diagnosis before his CT scan. So instead of getting a CT scan to rule out his pulmonary embolus, he got a not beautiful barium swallow. But even though it's not beautiful, it certainly shows that he's dumped a bunch of contrast out into his mediastinum. And I think after a slightly rocky course, he did well. But this is, as you have all been mumbling, Boerhaave syndrome. You know, it was a long time before I saw my first case of one of these. It is the rupture of the esophagus due to submucosal dissection after vigorous vomiting. Patients on plain film will present with pneumomediastinum, subcutaneous air, and pleural effusion. Now, I don't know about all of you, but I was taught erroneously, and may have promulgated this myth, that Boerhaave was not the doctor who figured out, but it was the patient. Yeah, but you know what? It's a lie.
Is it?
It's Hermann Boerhaave. He was a doctor. He was a very important surgeon in the 17th century who...
He was the patient.
No. The patient was Baron Jan von Wessenaar. We'll get to that. Anyway, Boerhaave was an important early proponent of the use of the Fahrenheit thermometer in physical examination, as well as the use of autopsies to determine the cause of death. And he did the autopsy on Baron Wessenaar, who was the admiral of the Dutch fleet and prefect of Rhineland, who died after vomiting up a large meal. And Boerhaave did his autopsy in 1724. This is Boerhaave. So, just in case you guys thought, like I thought for many years, that Boerhaave was the ship captain. No, he was more than a ship captain. He was in charge of the whole fleet, and Boerhaave was the doctor. Okay, my favorite request. All right, as the emergency room physicians here at NYU, one of our favorite responsibilities are reading a portion of the ICU films every morning, which for the most part are, well, they're challenging because they're not beautiful films to look at, and they don't change much most of the time. But every once in a while, the problem with ICU films is every once in a while there's some disaster on them. And this patient came in one day, or was in the unit one day, and this is one of their many films. And we, you know, the first thing obviously we teach our residents, and then we sort of pay attention to what? Tubes and lines. And unfortunately, it's very hard to get our technologists to remove all of the tubes that are lying over the patient. So sometimes this can be quite a jumble of figuring out what's what and what's where. For example, last night I was looking at a patient who'd had a number of ventricular peritoneal shunts, most of which had been left in, some of which were connected, some of which weren't connected. It was, so we're going to be just fine. We'll be right on schedule. Okay, what do you think?
The Boerhaave tube's in the right chest.
It is. It is in the right chest, and it has perforated the lung. So what do? You pull it out, and that's right. Our next case, of course, is pneumothorax. Okay, line malposition, just to finish up, is there are numerous places that people can put lines. This is just one of the many possibilities. I am never amazed by where people have managed to put a Boerhaave tube. The other night, somebody put one down the right mainstem bronchus, realized it was down the right mainstem bronchus, repositioned it, got another film. It was in the left mainstem bronchus. Finally, they hit the esophagus on the next try.